67% patients had moderate to severe side effects. 43% had to discontinue BCG. 20% required anti-tubercular therapy. 11% required a cystectomy. These numbers might seem a little higher than what we actually see in our clinical practice. Bottom line is patients face a lot of problems when they are on BCG therapy. We have another paper from the group at Adyar. 96% of their patients would complete the induction phase, but a one-third needed some breaks to complete the phase. One difference in their schedule is that they give monthly maintenance, probably a little more tolerated better. We have unpublished data from TMH where we looked at 100 of our patients. They received the Moscow strain. 37% had to discontinue. So how do we make intravesical BCG more tolerable for our patients? We allow a minimum of 2 weeks after TURBT to allow that scarred area to heal. We educate the patient about expected side effects right in the beginning. We tell them that you are going to face mild symptoms in about 60% of our patients, severe symptoms in about a third of our patients, about a third are going to actually discontinue BCG. So when we tell them that we cannot give you more BCG, they are in fact bothered about the oncological outcome because they're like, you're not giving us treatment now. Electively use a lower dose of BCG in the elderly and in those with existing symptoms. This is sometimes that we take a clinical call, 70, 75-year-old, already having LUTs, probably give a 40 mg dose of BCG in the clinic. We obviously want to rule out a UTI, ask the patient how he tolerated BCG the last time before you put in the drug again. Always instill under gravity. Don't push for 2 hours. Tell the patient 2 hours is what I would like. 1 hour is enough if you can do that. And you may reduce the dose or change to something more tolerable if there are signs of intolerance. Coming to post-cystectomy, now why is QOL important here? Nobody wants their bladder removed, right? Nobody wants to undergo a cystectomy. Most common diversion that we do is the condio, and it's a body disfiguring surgery. NMIBC patients who undergo a cystectomy and PT2N0 patients, they live long, right? So these patients' quality of life becomes much more important a few months after they have undergone the surgery. Does the approach matter? This is from the RAZOR trial. They used these two questionnaires, the FACT index and the short form 8 health survey. We'll come to it again later on. They assessed QOL parameters at baseline, 3 months and 6 months. As I told you, that is how they do in most papers. They did not find any significant differences at any time point. All of our surgeons, when we see an open cystectomy patient, the patient is usually not sitting up well in bed the next day, but the robotic patient is probably sitting up in bed the next day. So these questionnaires actually look at quality of life. That is what I'm telling you. 3 months is a little too late to assess if the robotic surgery had an effect better than open surgery, because robotic surgery helps the patient go back home early. But at 3 months of time, that difference has probably gone away. Does the type of diversion matter? So all our data is retrospective over here, but it usually points towards the fact that neobladder may be better than the ileal condio. But the patients, if you help them, they learn to live with the condio without having any inhibitions in their day-to-day activities over the long time. And that is why even if patients perceive that a neobladder is a better diversion, it has to be a shared decision. If the patient understands that he's not going to do CIC, he's not going to do his own bladder washes, he does not want to wear the diaper, but he's okay with the bag which is hidden under his shirt, he probably wants a condio, and that is what you should give him. This is the short form 8 questionnaire. This is one questionnaire that can be used in the clinic. First question, overall, how do you rate your health? Second question, does your current physical status limit your physical activities, daily physical activities? Are you able to do your daily work at home? Do you have bodily pain? These are the first 4 questions. Very simple for the patient to answer. Next 4 questions, how much energy do you have? So basically, how active do you feel? Does your current problems limit your usual social activities? Are you bothered by emotional problems? And do they prevent you from your daily activities? So we wanted overall QOL, and we broke it down into physical, psychological, and sexual. These 8 questions give you a very basic idea about the physical and psychological status of the patient. You can ask him or her a few questions separately about the sexual health, and you have your own personalized overall QOL in the clinic. How do we improve QOL after cystectomy? So we counsel the patient rightly and have the post-op expectations set right at the beginning. We select the right treatment option for the right patient, whether you want to give neoadjuvant therapy, whether you want to give adjuvant therapy, the patient has PCNs, you want to first operate, get rid of the tubes, because moving around with tubes is also a quality of life index, which is not captured by any of the questionnaires. The approach probably does not matter. The type of diversion probably does matter. And nerve-sparing cystectomy may probably give you better sexual outcomes. The support system, right? So we had a representative from Littlemore yesterday on the dais with us, Ostomy India, Bladder Cancer India. These are forums, patient support groups, which is going to help the patient, cross that journey from the day of surgery till coming back to how he was living life prior to the surgery. These are some images from our stoma care clinic in TMH. And basically, patients meet the stoma staff. They meet patients who have already had surgery, so that there is some survivorship clinic happening there. Last 3-4 slides. QOL inherently, is it better than cystectomy with bladder preservation? Because the patient retains the bladder, there is no post-op comorbidity, there is definitely no mortality, but it does have its own QOL issues. So we use routine questionnaires even in the papers, and the RT-OG grading is used. We have unpublished data from TMH, where we have found that the urinary and bowel system domains are the same for both. Sexual domain was better with RT. It's probably very obvious. This is a prospective collection that we have begun doing, the compact study. We are aiming for 250 patients. We'll be using those questionnaires and keep on following patients till they have a metastatic recurrence. What numbers do you tell your patients? You tell your patients right at the beginning for a surgery, 2/3 are going to have minor complications, 15% major complications, 2% will not go home. CTRT, severe grade 3 complications, 2%, mild to moderate. I've taken these numbers from a radiation onc colleague, so I'm not extrapolating them or saying wrong numbers. 15% need a salvage cystectomy. Finally, QOL is as important to the patient as the oncological outcome. Objective and validated tools are used in the research setting. In the clinic, you can use these tools. The SF8 is a fantastic tool to capture it. You look at physical, psychological, and sexual domains, and then you get your overall picture. Counsel patients with honest numbers. Intermediate and long-term outcomes don't depend on modality of treatment, don't depend on open versus MIS. Neobladder is probably better than a condio. Most patients will learn to live with the changes in QOL. Physical and psychological scores recover. Sexual scores take a little longer and mostly don't recover. This is the most number of times during a talk that I've looked at the timer, because I don't have a timer here.
5 minutes for discussion. Thank you so much, Dr. Amandeep.
Thank you. Thank you,
You
Aman.
have 5 minutes.
Yeah.
Thank you, Doc.
So, I have been favoring, collecting questions, answers, whatever. So, the one who's asking the questions is very important.
Right.
I cannot ask a CS cervix patient who has undergone radiation about her sexual health.
Yes.
A lady did it for me who was elderly, and she knew exactly what to ask.
Right. Right.
So if there was another resident of mine who did that, tried to do that at least, but they couldn't get the similar answers what the elderly lady was doing.
Right.
So it's totally different. Our subset of patients is, you cannot apply these RTOG,
Yes.
EORTC, QL, all those.
Yes. So in literature, all of these are self-administered questionnaires, but a lot of our patients require vernacular versions of these questionnaires, and even then they would require help to make them understand that this is what we are trying to ask you.
No,
Most of the times we ask the question and then record their answer.
No, most importantly, who's asking
Yes.
and how we ask.
Yes.
Most of the doctors don't know how to ask.
I agree.
Because they call up, they say, they just rattle it out like a parrot, and they expect answers. The patient has to think. You don't give them. You send a mail, they don't want to, they don't reply.
Yes. Yes.
So
So we
telephone
have to
call
respect the social thing in our
setup,
society.
when they come to the OPD, we spend about 5-10 minutes. In your setup, it's impossible.
Yes. Yes.
So these studies are all vague.
Yes.
And we don't even give some kind of a literature or a form before treatment.
Yes.
What to
Next
expect,
question,
how much
please.
of energy you have, that's vague. I cannot answer.
Yes.
Next question, please. Sir,
Ah.
we're waiting.
Thank you, doctor. I get the figures right. It is only 15% of the post-RT patients required a cystectomy.
Yes.
Is that the figures
Yes.
right?
So the figures were around 30% earlier.
Ah.
The most recent papers, 15%.
At what time it is you're
I'm
talking
sure
time
Vedant
frame?
sir, if here is, he would think that.
Time frame of 5 years you're talking around?
Yeah.
Okay.
Yeah. Yeah.
The other thing you mentioned is that the urinary and bowel scores were similar between those who received radiation and those who underwent cystectomy.
Yeah.
But would there be any difference in terms of temporal profile? When did you measure that?
Yeah, so they were they were measured at baseline 3 months, 6 months, like in any other paper. The urinary symptoms for the cystectomy patients were mostly calculated for the patients who had a continent diversion, because for the incontinent diversion there is nothing much that you can really ask them.
I mean, it's very ironic that if you preserve the bladder, the QOL is the same. And that means the QOL questionnaires are not really capturing the real thing. It's very ironic.
Yeah, so these are the limitations that are written at the end of every paper that reports on QOL, that this is what we have, this is validated in other studies, but still we are not really sure if we are capturing what we want to capture. Because what we begin thinking that let's do a QOL study, CTRT definitely has better QOL than cystectomy, probably does not come out. Robotics definitely has better QOL than open. Is it the questionnaire at fault that is not capturing what we think it is supposed to capture?
Dr. Amandeep, thank you for bringing this important issue and under the discussion. So most of the time as a clinician, we discuss about the updated evidence and think that the patient will live better, longer with all this treatment. But actually, we never had thought about this issue in our clinical practice.
Yes.
We also have a lots of, in our setup, I'm from Kathmandu, and in our setup, it's very difficult to give a time in our OPDs with this patient and discuss about their quality of life and expectation.
Yes.
So I think it is very mandatory that someone, at least in a clinics and a ward, think about their quality of life.
And that is why you use the shortest possible questionnaire, which is the SF8, probably. Yeah.
So I think we need to incorporate our practice, at least in the clinics, to assess about what are their expectations. So thinking about this BCG, I would like to make a comment. I think that the BCG, there is evidence that it prevents recurrence, but how many patients are really benefited from those, and what are their life is being? I am sure this BCG discontinuation, you showed it about 50%. I'm sure it's more that high than the 50%. I have not seen patients who are completed 3 years with BCG. They will have a sepsis. They will end up in the ICUs with all those anti-tubercular treatment and all. So I think this part we need to discuss in details, and at least not in OPD setting may not be possible, but in a ward setting, I think we need to have this QOL assessment.
Agree, sir.
I think I disagree with you on the BCG 50% discontinuation rate, but that's a discussion for a later date. I don't think it's that high, and the BCG complications are overrated than what I think time is out, we'll discuss later.
Thank you, Dr. Amandeep Singh Arora. I would now like to invite...
The last question.
No, sir, I'm sorry, I cannot allow. We are already 5 to 7 minutes late. You can discuss at the tea time, in the tea break, sir. May I request Dr. Mahendra Pal, who's a professor uro-oncology from Tata Memorial Hospital, Mumbai, and he'll be speaking on optimizing surveillance protocols in bladder cancer for India. Over to you, Dr. Mahendra Pal. You've got 9 plus 6 minutes. Thank you.
Thank you. So, optimizing the surveillance protocol bladder cancer in India. And as Amandeep said very well, by this strategy, we are making patient to live longer with good quality of life if we adopt adequate and effective surveillance for any cancer. So what do an oncologist wants during the surveillance? Like no recurrence, detection of early recurrence, the side effects of the treatments, good health of the patient, good functional status, and good quality of life of the patient. But in reality, what do our patient need actually during the surveillance? Is it an assurance, safety and reliability, accessibility for the healthcare, minimum discomfort, low cost, and definitely a minimum travel to go for the surveillance. Hurdles in India, a fusion factor, heterogeneity in the guidelines-based following up or expert opinion, patient data, quality of medical care is not this equal everywhere. Patient factor, adherence to the advice, the compliance, demography, geography difference over the country, cost factor, another that we really do not know because we do not discuss all these things with the patient. So coming to non-muscle invasive bladder cancer, that generally focuses on the disease progression and the recurrence, and maybe the side effect of the BCG related treatment. As we see all the guidelines have a similar follow-up schedule for the low-grade cancer and as well as the high-grade cancer, but none of the guidelines define exactly what is intermediate risk. And as per the follow-up, as we can see, there's always all weak recommendation. And for intermediate, we don't know how to follow up. It should be individualized. And for high-risk patient, it is yearly after the 5 year. But how long? It is lifelong for 30-year patient, or lifelong, or maybe it has some time frame for that. This article, when it go through the low-risk NMIBC, and it concluded that there is an overuse of scopy in about 3/4 of the patient, and the patient care and having tumor comorbidities and earlier diagnosis, as well as multifocal tumor, are associated with the overuse of cystoscopy, and they concluded, and they also raised the concern about the bladder cancer surveillance cost and the quality in the low-risk NMIBC. This retrospective study of 428 patients which focused on the high-risk NMIBC, and what they did, they, as per the EU guideline, they followed the patient for 10 years, and they proposed a follow-up schedule which was almost equal with the recurrence rate and the progression rate as well as the EU guidelines, and they proposed a little bit stringent follow-up for the high-risk NMIBC and with the highest risk NMIBC. What they did, for the cystoscopy and other follow-up, they modified compared to the EU guidelines, and they have some intense follow-up initial period where has the highest risk of the patient, and along with the reduction rate of 40% the cost of for the patient. And they concluded that this certification of the highest risk, high risk NMIBC could potentially reduce over investigation during follow-up and improve surveillance cost for the patient. This again, a recent article 21, follow-up in the non-muscle invasive factor in the future. They concluded that follow-up in MIBC is too frequent, with low level of evidence and suboptimal tools. And this article focused about the one which never discussed is the patient unfriendly and the costly aspect in the guide, which not in the guidelines. And again, they said urinary markers have been around for decades, but still they are not a gold standard which can replace the cystoscopy. Again, if it's the cost, as we can see that high-risk NMIBC has the highest burden of the cost as well as disease progression, and this article concluded that it would be prudent for us to lower the intensity of the surveillance for the lower-risk NMIBC, but it should not be compromised the outcome of the high-risk NMIBC. So my point of view, session for the NMIBC, a surveillance point of view, the number of follow-up cystoscopy should be needed to reduce, at least for the low risk and few percent of the high risk or intermediate risk of the patient. Maybe the 3 months annually, then 5 year, or maybe less for low risk. High risk, 3 monthly can be done, but for how long? And